atop Cesar Rodney Square in beautiful downtown Wilmington, Delaware, home of the 46th President of these United States of America. We are the Podcast Pediatrician.
I'm Matt Gotthold.
And I'm Rob Walter. Check us out on Facebook and thepodcastpediatricians.com. And so we're doing this by Zoom because Matt's too scared to come into my domicile. And it's been about 2 months since our last podcast. Getting kind of tired of COVID-19. How about you, Matty?
Not so much tired of. Questions will really beat you down, just when you think you figured everything out in terms of being able to tell your staff how to answer things, one more twist comes down the block. So it's been an academic adventure. For us, that's a little bit better than the kinds of things other people, unfortunately, have been put through.
We've had, a good number of cases and some Thanksgiving cases. And even families that had, 6 or 7 people, there's always like that one uncle who comes. I had one think, it was the uncle, and kids no one's gotten really sick because kids don't get that sick, but it's all the grandparents we worry about. So we are entering the worst period by far. Worse, I think we both agreed, than last spring. It's hard not to get a little pandemic burnout for our families and everybody, but again, we have to be vigilant and continue to not backslide in distancing and masking. I think we both thought it was time to get back to our regular common office disease topics, and today is an epic episode on eczema, including newer approaches with proactive therapy and biologics. But we will still start with a few things related to COVID-19, and of course, we start with our disclaimer. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care.
And happy Thanksgiving and Hanukkah to everyone. So my Thanksgiving was actually a great one. All my kids were home. My one daughter came home from Virginia. Other one came home from her apartment. And my son came home from the University of Delaware.
For me, got to see both my kids over the Thanksgiving weekend, but it's a bit bittersweet. As Matt knows, my dad passed away a few months ago, not from COVID. I did drive up to see my mom in New York, and we social distance outside. And with all that, we both know we're grateful to be able to continue practicing pediatrics independently and serve our community. And want to thank Matt specifically for a little pre-Thanksgiving sausage and fire pit Friday night fiesta last week. Brought out the inner pyromaniac in me. I'm just like, what are you doing, Rob? I'm just playing with the fire. That's all I want to do. And no bacon sandwiches, but sausage sandwiches were quite good.
As long as pork of some type is on the menu, I'm in. Yeah, it was great. I tried to decide how I could get a few buddies together and socially distance, and the fire pit seemed like an adequate means to do that. Some adult beverages, and off we went to town. So it was really nice just to sit around and hang out with you guys. So I think both our offices are still a bit slower than usual, but the number of sick visits has started to creep up slowly. It's sad that we're both reading and hearing about more and more pediatric caregivers and doctors and nurses of all stripes who are deciding to retire early or to close up shop because of the current stressors, both personally and financially, caused by this pandemic.
Yeah, we both know quite a few number of docs who are calling it quits. I'm hoping that us in pediatrics will get a little bit of a pandemic baby boom, since it's been about 9 months since the lockdown started. Unfortunately, though, maybe with Netflix and other streaming choices, these parents are not canoodling as much as they would have been in the old days of a pandemic. And speaking of Netflix, have you seen The Queen's Gambit? Have you seen it yet, Matt?
I've not, but I do want to put in a plug for canoodling, because we pediatricians can use that.
Well, I just want to say The Queen's Gambit is so good, even if you hate chess. And anybody who kind of likes sports, you'll love Ted Lasso on Apple TV, too. So, debates are raging about school openings and closings. I think we both stated pretty emphatically early on in this pandemic that in-person learning is crucial, the emotional, educational, and physical well-being of many of our pediatric patients, and that childhood education should be prioritized over activities that involve adult social pursuits like bars and restaurants. But yet everybody has their own bubble, and any decision about sending one's child to in-person school is going to be the right one for that family. But it is nice having in-person options, and using a scientific approach to deciding that is ideal. The Delaware Public Schools have started to reopen to some extent, but in fits and starts, and then this week, they're all starting to close again.
Yeah, my oldest daughter is a kindergarten teacher, and she yesterday was her last day in the classroom for quite a while. So yeah, it's being played really kind of week to week, month to month, and I think appropriately so.
Right.
I think that we have to be sensitive to the fact that different people have different needs, and that you try things and you see how they go, and you check the environment and see how safe it is, and then move forward accordingly. So in this episode, we'll very briefly touch on two COVID-related issues that often come up in the office: COVID testing and COVID vaccines. As we detailed in previous episodes, there are two main types of tests for the novel coronavirus: rapid antigen tests, done with a sample from the nose, and molecular PCR, or polymerase chain reaction tests, done with a sample from the mouth or the nose. I always tell patient families to make sure they ask exactly which one of these two types were done or are considering being done when it's not being ordered by one of our providers and it's being done somewhere outside of our office. And now, tests are being done by mail as well. We know that the PCR test is a superior test at this point, with greater accuracy based on higher sensitivity and specificity. However, these can be more difficult to access in the community, and the results sometimes don't come back for 4 or 5 or more days, which can make their usefulness a bit limited. We think at this point that a positive or a negative PCR test is legitimate. Most of the crummy rush to the market, fly-by-the-night tests in this category have fallen by the wayside. But a key point we want to comment on is the principle of pre-test probability, especially for the rapid COVID antigen tests. If one's trying to interpret the test of a rapid antigen test, which is not as accurate as a PCR, the pre-test probability of a COVID infection is the key to interpreting the results.
So if a child has a low pre-test probability, such as a patient with no close contacts with COVID-19 and no symptoms, or even a child with a single low-risk non-cough symptom for less than 2 days, like we talked about last episode, then a negative rapid test can be reasonably interpreted to mean the patient doesn't have COVID. In this instance, the recommendation would be to continue with social distancing and masks. Nothing's 100%, and as the White House learned, there can still be early cases of COVID present. But by reasonable risk calculations, if a test is negative, then one can stop the workup and consider the patient to be negative. However, if that same low-risk child ends up with a positive rapid, then the healthcare investigator should not stop there. With this type of situation, the positive rapid test needs to be confirmed with either another rapid test or, more optimally, with a PCR test, and the patient needs to be isolated until the results of that second test. If a second rapid test is done right away and the second one is negative, then the child is stuck in COVID limbo until the results of the more definitive PCR test is available.
I like the COVID limbo thing, man. That was really
I know.
That was a cool term of phrase you
COVID
put in there.
limbo.
My Catholicism goes straight to sentiment there.
Yes, but I think we talked about, the Pope got rid of limbo a couple years ago.
Still part of the history.
Okay.
Got to go there.
Okay.
So what about getting the rapid antigen tests on the high probability kids, those with definite COVID-19 close contacts of less than 6 feet distance for more than 15 minutes, or with respiratory symptoms, or the loss of taste or smell, or with multiple other symptoms? Well, if these high probability children are negative on a rapid antigen test, then they still need to be considered as a person under investigation, a PUI, and they need to be isolated until a reflex PCR result can be obtained. However, if the rapid antigen test is positive for a high probability kid, then they probably have COVID-19 and no more testing needs to be done.
And so I know we're not completely in agreement. I am more using the rapids than you, but for some of these clear-cut cases, it almost is like our rapid strep tests that we back up with a regular culture if it's negative. And in some ways, these rapid COVID tests are more accurate than the rapid strep tests. Okay, another hold your presses here, but the CDC just 2 days ago shortened the quarantine time for COVID exposure. The recommendation is that a person with close contact with COVID exposure, the quarantine can be decreased from 14 days to 10 days, and even down to 7 days if they get a negative COVID test back from 5 to 7 days, and that could even be a rapid test alone. Now, Craig Shapiro, our ID guru at DuPont, sent us a table about the CDC detailing the residual post-quarantine transmission risks with and without the testing within 48 hours of ending quarantine. So at 14 days, the quarantine risk is 0.1%. When you shorten it to 10 days without testing, which they said you can do, that risk goes up to 1.4%. If you shortened it to 7 days by getting a test at 5 or 6 days, the risk goes down to 4% if you get a PCR, and if you get a rapid, it goes down to 5.5%, which gets to the point that they can say that, but the gold standard, I think we agree, Matt, it's still 14 days. If you go down to 10, it's 1%, but then you go to 7, even if you're talking 4 to 6%, that's a high percentage, especially if you have high-risk people in your bubble. So even though they say that, I'm still kind of saying 14 days is the gold standard. If your families can do that, that would be better. How about you?
Yeah, we actually recently had 2 staff members who unfortunately came into contact with positive COVID cases prior to them being identified. And we had them sit out the full 2 weeks. You know, they had symptoms. They still have no symptoms, but it's just the prudent thing to do. Now, we did have to kind of do a pre-mortem here and say, like, okay, well, what if we have so many staff members who were in that circumstance that it's going to be difficult for us to function as an office? I think we cross that bridge when we come to it. I mean, clearly there are people in hospital settings and other more acute care settings where situations are a lot more serious who have skills that are necessary, and they are donning full PPE and working as they work their way through their sickness. Thankfully, we didn't think that our situation was such that was something that was appropriate in our circumstance. But, down the line, as we know, healthcare workers are a rare resource.
Right, you're right. And I know that our local hospital, I've talked to quite a few disgruntled employees who say anybody in quarantine, they're having them come back, so that they have to come back to work if they're in quarantine. In North Dakota, doctors with active disease, if they have no symptoms, they're asking to work, and that seems crazy to me, but I guess they don't have anybody else to do it. I agree with you, though. We've talked about, 14 days is nice, but maybe they can come back earlier if we have short of staff. And obviously, depending on how they come back, if they're not directly in patient care, if they're on their phones, that would be more palatable. Limiting factor, talking about back in the spring, it was respirators and such and PPEs. Limiting factor as we ramp up again is staff. That's the problem with all the hospitals. They just don't have enough staff.
Absolutely. And we've had to even think outside the box a little bit in terms of running our office, Rob, and you just alluded to it. Maybe some of the folks who are home on quarantine, if unfortunately we get there again, are going to be able to work from home doing some telephone triage or some other aspects of what we can do, now that we use computers so readily in our offices for a variety of different things. So,
right.
There are options. I think that the point of this is not only do we want to protect our staff, but we also want to protect our patients and their families.
Right.
So how about those COVID vaccines, Rob? We get asked about them a lot, and if they're safe. And I'll be honest with you, when people talked to me about this maybe 2 or 3 months ago, I wasn't real positive about being eager to say, yeah, you got to run out there and get those things as soon as they get out here, like oftentimes we are, because the window of research has been, really short at this point. But I got to tell you, I was bowled over by the results of this, the 95% efficacy of these vaccines. That's virtually unheard of in the vaccine world. We're talking like MMR type immunity, and that's impressive. I don't know. What do you think?
I agree. I'm extremely excited when I hear those numbers and the possibility of getting this vaccine very quickly. But the 2 main ones are messenger RNA technology, which has never been used, and they're put in some lipids, and it goes into a patient's cytoplasm cells, not in their nucleus, and then the patient who gets it makes their own proteins, which are those surface proteins, and that produces an antibody response, so completely different. And it all gets back right to the safety. So far, they've done tens of thousands of people, and it's been very safe. I've heard experts, Anthony Fauci says, get it. I'm feeling very comfortable. I don't think anyone can completely take away the thought, what if something unexpected pops up down the line? And it's happened rarely before, but most things, they usually come up within 2 or 3 months. And we've had that long. So I remain excited, but understand why there is some worry out there, and we'll talk about that. And Matt, at least initially, I'm not sure us private offices will be able to stock many of these vaccines, not only due to supplies and the prioritization of essential workers in high-risk populations like nursing homes, but also that specific equipment like those ultra-cold refrigerators are needed for some of the newer ones, especially the messenger RNA. It looks like the initial vaccines will be 2 doses about a month apart, and children who do have this innate immunity most likely will be at the back of the line. But they are now doing some safety trials on kids. I think looking at it that it should be available enough for kids that the fall school season would be able to comfortably start with most kids getting vaccinated. And that's my hope. And I think that's what they're aiming towards, is that getting them back fully in school in the fall.
Yeah, that's certainly been my understanding of it, Rob. Like anything else that we're looking forward to, even in life, always good that, like when you're looking forward to seeing me, always kind of good to put a delay on that.
It looks like healthcare workers will be prioritized, and then nursing homes, and then people with high-risk conditions, and then this spring, most of the families of young adults in our practice. When you look at population studies, 12% of healthcare workers have been infected with COVID, compared to 3.4% of the general population. And this comes with more complications, more deaths, more physician burnout, and as we started at the beginning, more people leaving the profession. So I'm very comfortable that healthcare workers, especially first-line workers, will be the first ones to get it for many reasons. But we need to also keep in mind communities of color and high poverty, because they're really high risk too, and they don't have as much economic clout to get in the line. And I'm hoping that their voice will be heard as all this vaccine gets rolled out. So, Maddie, are you ready to be one of the first people to get it when it's offered?
If Dr. Fauci's willing to do it, I'm willing to do it. Yeah, I mean, show me the needle. Here I go.
I'll be right next to you.
All right. I mean,
well, I'll be in front of you. I'll be in front of you. I'll kind of push you.
We'll see about that.
Okay.
Yeah, so I was fascinated by an article that came out last week in Microbiology, and it showed, like we discussed before, vaccinations that one may have already had can provide some protection against severe illness from COVID-19, and not, obviously not COVID-19 vaccinations, because they're not out yet, but we're talking about the accumulation of vaccines that one has had previously, and or some of the specific ones. So the article focused on this type of protection being engendered by the MMR vaccine, and specifically from the mumps component of the MMR. So the MMR vaccine, as most of us are aware, is one of the vaccines that's been extensively demonized in the anti-vaccine circles, which is so scientifically baseless and unfortunate. It's a shame. But this recent article builds on another article from September in the Journal of Allergy that showed the same type of phenomenon. And ironically enough, the anti-vaccine movement seems to have gotten even bolder and arguably even stronger with the COVID pandemic, which just, I try to see things from all angles, man, but there's just no logic to that.
Yeah, that's really tough. I don't know about you, but I've started to routinely ask my families in the room if they would get a COVID-19 vaccine when it's available and passes the safety test. And I shouldn't be surprised, but I still always am when many families say absolutely not. And my observation has been that this sentiment seems to be more common in my families of color. I do understand that after generations of institutional racism in medical care, that this response is understandable, but it's frustrating. These are great parents, and many of them still will get the flu shot and other vaccines. So part of it is certainly that the COVID vaccine waters have been muddied of late by lots of misinformation. I think it's part of our jobs when we see our patients, even before the vaccine comes out, to kind of explore that and have them and talk about it, and talk about that if we don't do this together, this is going to last for years.
Yeah, so here's a sad, weird story. We know that animals like cats and dogs can get infected, but one animal in particular that can become infected in large numbers and can serve as a source of infection to humans is minks. So Denmark, as it turns out, is the world's largest producer of minks.
Who would have known that?
Right?
Right.
Who knew, right? There's some evidence that the infected minks are more likely to trigger genetic mutations in the novel coronavirus, which can then infect humans. So Denmark culled millions of minks and then buried them, perhaps a bit hastily, in shallow graves. This is where it gets even more interesting.
Yeah,
As they decomposed, gases were released, which actually caused many of these minks to be lifted up from their shallow graves to the surface, kind of like floating zombie minks, right? So this, understandably, freaked out lots of Danes, and it will likely result in these zombie minks needing to be incinerated. Yeah, nasty business there, I must say.
Ooh, it's like walking zombie dead.
Okay, after the break, we'll be right back. Okay, and just a word about our sponsors. So Julie Ortiz and Triage for Pediatrics, they've been a tremendous boon to our practice in terms of after-hours support. You can contact Julie at phone number 214-450-5030. It's Julie Ortiz, and it's Triage for Pediatrics.
And also High Fives, the number 5S, by Jim Hansen, the Marine. His company will do everything for you in website development, PHP programming, systems administrations, and systems security. There's been a lot of ransomware attacks on a lot of businesses, including medical businesses, in the past just month. He's great, and I recommend him. His phone number is 877-483-1040. And now we are back.
All right, let's change the subject on this and get to some eczema.
Eczema!
All right, let's readjust here. So atopic dermatitis, or eczema, most people will consider them to be the same thing, although there are some subtle differences, is the itch that rashes. Or maybe it's the rash that itches. Anyway, it's really, really itchy. Today, we cover this dermatologic curse of infants, children, teens, and adults everywhere. So eczema affects over 30 million people in the United States alone, or about 10% of the population. About 10% of pediatric patients under 18 have it, which makes sense, and that's 10 million kids. And the incidence seems to be rising. In the vast majority of these children, this condition begins before they are even 5 years old. And statistically, childhood eczema will persist into adulthood for about half of these kids.
And I've had some of these kids with severe eczema over the years. And it's just frustrating. It's frustrating to watch them suffer, and as pediatricians, sometimes feel kind of helpless in many ways. And then for these families, these parents, it's kind of horrible. How about you, Matt?
Yeah, I mean, when 1 in 10 kids has this condition, it really is something that becomes commonplace. I mean, even Rob, to the extent, and I'm kind of embarrassed to admit this, but I'll see a kid and see a kid and see a kid, and then finally say to the parent, you know what, have we ever talked about their skin? And the parent will give me this, glum look. No, it's bad, isn't it? I'm like, okay, well, let's take 10 minutes here and put a plan together, because, this does not necessarily have to be the way it is. I know your child has sensitive, dry, eczematous skin, but let's try to put something together so that they become more comfortable, because as we'll talk about in a few minutes, this can really be the bane of many a child's existence, and they have little ability to protect themselves. We and their parents are there, presumably, to be helpful in terms of making them more comfortable, because this can be a misery.
Yes, and after you finish listening to this podcast, you will be able to put together a plan, mild, moderate, severe, cutting edge, and fix them all, even Matt.
Woohoo! Can we really be fixed, Rob? Should we go existential on that? Yes, for discussion, we're going to lean heavily on excellent eczema talks by Dr. Jim Treat, a star dermatologist from CHOP, who presented a nice lecture that both Rob and I heard last year, and by Dr. John Spergel, head of allergy at CHOP, who was the keynote speaker at the all-virtual ROI Warren Conference early this November. We've also drawn on information from the wonderful up-to-date website's Child Eczema section, authored by Doctors William Weston and William Howe. As always, any errors or stupid comments going to put forth on the airways here due to our own ineptitude and not theirs. These physicians are brilliant, and we are only the humble conduits for some of their wonderful information and insights.
And I must say, moderating that day-long ROI Warren last month was not very fun. I was sitting there making jokes, wearing different masks, wearing it below my nose, showing how ridiculous people are in this silent vacuum. And it kind of felt like if you're like a stand-up comedian and you're completely bombing without any alcohol. It was something I did not like.
You should be used to that experience, man.
Right.
All the other times I've seen you host a conference, that's generally the sentiment. So eczema, from the Greek eczema, literally something thrown out by heat. From eczeme, to boil over or break out. From ek, out. Eczema is not a condition in itself, but a description for a group of skin diseases that cause skin inflammation and irritation. However, we in this podcast will assimilate eczema and atopic dermatitis to essentially be the same entity. So there are at least 11 distinct types of conditions that people will refer to as eczema. So eczema is sometimes called, as I said, atopic dermatitis, which is the most common form of eczema. Atopic refers to allergy. People with eczema often have allergies or asthma, along with itchy red skin.
Okay, so we're not going to get too deep in the pathophysiology of eczema, but there are many factors in play. And they can be roughly divided into the outside-in hypothesis of skin barrier dysfunction of the epidermis and the inside-out hypothesis that focuses on immune dysregulation as the phenomenon leading to eczema. So first, the outside-in. A huge source of eczema are abnormalities of one of the over 70 filigrin or FLG genes. And these loss-of-function mutations of this gene causes the filigrin protein deficiency, which leads to a defective skin barrier. There are other genes involved in the epidermal barrier, including the PP5 gene, not to be confused with Leon Spinks. So we're of a certain age, Matt. Do you remember when Leon Spinks upset Muhammad Ali?
Absolutely.
February 15th, 1978, in a 15-round split decision in Vegas, Leon Spinks was the only man to take a title from Muhammad Ali into the ring. Ali's other losses were non-title contests or fights when he was the challenger. Leon Spinks also won a gold medal in the 76 Summer Olympics in the light heavyweight division. In the same Olympics, his brother Michael Spinks won a gold medal in the middleweight division. And you remember Michael Spinks, who lost the fight of the century to Mike Tyson in 91 seconds after all this pay-per-view? It was a total disaster. And you just even remember boxing, Olympic and pro, when it was really, really popular. Most of us don't watch it now. The brain injuries are horrific. But back in the day, we watched, and I vividly remember watching the greatest boxing upset in history when undefeated Mike Tyson lost to who, Matt?
Well, that would have to be Buster Douglas.
Buster.
By the way, whose dad was a boxer as well, who had the very cool name of William Dynamite Douglas.
Did not know that.
Yeah. So Buster Douglas knocked out Tyson in the 10th round to claim the WBC, WBA, and IBF titles. He was the world heavyweight champion for 8 months until he was defeated by Evander Holyfield, whose ear Mike Tyson later bit off.
Oh, the ear!
In his only defense.
Oh, that was disgusting.
So the biting incident, also known as the bite fight, went into the annals of boxing as one of the most bizarre fights in history. The craziness happened in the 3rd round when Mike Tyson bit Holyfield on one of his ears and then consequently had 2 points taken off of his score. The referee decided to disqualify Tyson at the time, but after Holyfield and the ringside doctor intervened, they said that no, Holyfield could continue, and so the ref let the fight continue. But then, in bizarre times too, Tyson bit Holyfield again, and this time, his teeth tore off the top section of Holyfield's ear.
I remember that.
Also known as the helix, by the way. And he spit it
yes.
onto the ring's canvas. It was entirely wacky.
Oh, and now Mike Tyson's coming back. He's going to be fighting next week in pay-per-view.
I know. So that was back when, just crazy.
Back then, there were a lot of big personalities, and we did ignore the brutality and the brain-shaking injuries. But my last boxing question, do you know the Muhammad Ali song?
No, I don't.
Here's your hint. It's called Black Superman.
I still don't.
Muhammad Ali, he floats like a butterfly, stings like a bee. Muhammad, the Black Superman, who calls to the other guy, I'm Ali. Catch me if you can. You don't know that song?
No, I don't. Atopic dermatitis is characterized by abnormalities of the skin barrier, such as the presence of filigrin mutations in almost 50% of patients with moderate or severe atopic dermatitis, and lipid disturbances, mainly expressed as insufficient ceramides. The protective structure consisting of these various substances can be adversely affected by having hard water. The simple definition of water hardness is the amount of dissolved calcium and magnesium in the water. So hard water is high in dissolved minerals. This type of water can actually double the risk for eczema. Delaware water is pretty hard, and you can tell this by the spots left on the glasses when you take them out of the dishwasher. Jersey water is also pretty hard. Pennsylvania water is even worse than that. But as we've talked about, New York water is relatively soft, which is why Rob says New York bagels have the best taste. And that their pizza crusts, Rob says, are the most delectable. But the research on the hard water and eczema connection is still incomplete, so I don't think any of us are telling our families with eczema to rush out and buy expensive water softening systems, although Rob may be telling them to run out and buy New York City pizzas and bagels.
Exactly.
Instead, take shorter baths and moisturize more.
Okay, now the inside-out hypothesis. This is all about the innate immune response that involves the interplay between keratinocytes, mast cells, microbial flora of the skin, and antimicrobial peptides, or AMPS, AMPs, in kids with and adults with eczema. So what occurs is a combination of this skin barrier disruption and immune activation by allergens and irritants, which is exacerbated by scratching. This environment turns on the immune system like the Th2 cells, which release inflammatory factors, and these factors excite the cutaneous sensory nerves on your skin, which activates the itch. And oh my gosh, we cannot stress enough the central role of the vicious itch and scratch cycle. When the skin's sensory nerves are activated, this leads to a person scratching. The scratching then causes the skin components to release more inflammatory mediators, which leads to more eczema changes and skin drying and more itching and then more scratching.
And to make this even more insufferable, the itch is worse at night. And this is for several reasons. First, body temperature goes down at night, and this promotes itchiness. Secondly, people tend to use moisturizer, which can relieve a lot of the itches only in the morning. So the relieving effect of the moisturizer has largely worn off by night. So take note, moisturize twice a day. Lastly, at night there are far fewer distractions, so the itch becomes much more evident than during the daytime, when we're occupied with so many other distractions. At night, it's just you and your thoughts and your dry, itchy skin.
Itchy.
But there could be a teleologic advantage to this situation. So, Roberto, why do you think we humans would have this itch response that causes so much damage and so much restless sleep?
I have no idea.
Well, it's thought that it's a remnant of prehistoric times. Millions of years ago, early humans would likely have had to scratch out a variety of worms and other parasites who were trying to take up residence under their skin in order to maintain that human's overall health and in order to survive. Having a built-in mechanism to serve as the system to alert our primitive ancestors to get rid of these cutaneous invaders. Evolutionary advantage. Always look at the evolution. Always ask why.
Yep.
Currently, most of us don't have lots of worms under our skin.
Well, in New Jersey, that's still true, right, Matt? You're
I was going to say
Jersey.
Current company excluded.
Yeah.
And the itch response is not helpful. But the urge and the instinct to scratch and itch is extremely powerful. This instinct is considered stronger than an addict's desire to take heroin.
Wow. I didn't realize that itching is such an innate, strong.
So, and weirdly enough, I don't know if you've ever seen heroin addicts, especially, the ones as played on TV, but they're forever itching also. They're like, wow, they're comparing one horrific, experience to another there, I think.
Right.
With all the various genes involved, with the chemical cascade, the different genes associated with that cascade lead to eczema, and it's not surprising that there's a strong genetic component to eczema. 70% of eczema patients have a family history of atopic or allergic diseases. Remember, atopy refers to a genetic tendency to develop allergic diseases like allergic rhinitis, asthma, and atopic dermatitis. So atopy is generally associated with a heightened immune response to common allergens, especially inhaled allergens and food allergens. If a child has one atopic parent, then they have a 2 to 3 times higher risk of developing eczema than if neither parent was atopic. This becomes a 5-fold higher risk if both parents are atopic. So, kids out there, do not marry your friends and associates who also have asthma and allergies and eczema, because you will make asthma-y, allergy, eczema-y babies.
That's so funny because sometimes we'll have, kids who have like bad eyes because one of the parents do, or one parent's always constipated, one of the kids are. And I say to the mom, like, so when you were dating, did you compare these notes to see what gene pool you're getting into? And the mom's always like, no. Or even like earwax, like, should have asked that. Could have been a game changer.
Shoulda, coulda, woulda. But on the earwax response, I would say that pretty much every mother in my practice has reported that her husband
It's always dad. It's always dad.
Always dad.
It doesn't make any sense. It has to be 50-50, but it's always dad's fault. Yep. So the key findings of eczema are dry skin and severe itching, but its presentation can vary a lot depending on the age and severity. In infants, the redness, dryness, and scaling is mostly seen on the face, on the trunk, which is the chest, abdomen, and back, and on the extensor surfaces of the extremities. As that infant moves into the older child years, atopic dermatitis mostly affects the flexural areas, like the classic antecubital space, which is the area inside the elbow when you flex it, and also the popliteal skin found behind the knees, and also the skin on the wrists and ankles. In adults, eczema often affects the hands. Now, eczema rarely affects the groin, buttocks, or areas under the arms.
So eczema is a disease of ups and downs, with calm periods of time and then periodic flare-ups. In mild eczema, there may simply be some dry skin patches that are not red or very itchy. In moderate eczema, though, areas of the skin are more itchy and red, and due to the scratching that occurs, parts of the affected skin can become thickened. This thickening is referred to as lichenification. So lichenified means the skin has become thickened and leathery. This often results from continuously rubbing or scratching the skin. When eczema is severe, it's both more widespread and more irritated and inflamed, with more redness and skin thickening. There's sometimes bleeding and cracking. Often there are alterations in the skin's pigmentation, with the skin affected becoming either darker or lighter than the surrounding skin. Severe eczema is often secondarily infected with Staph aureus, which has colonized those areas.
Now, some of the associated conditions we commonly see with kids with eczema is, one, keratosis pilaris. We always see this, and you always see this, Matt. It's that bumpy chicken skin we see in the upper arms, sometimes on the cheeks and the upper thighs. They could be skin colored, red, a bit scabbed, or a bit darker. And it's really cosmetically annoying for our patients and their parents. It definitely runs in families. It's an autosomal dominant condition, so usually one of their parents have it also. And unfortunately, there's no great treatment for it. It kind of waxes and wanes. Some people use lactic acid topicals in order to help to gently desquamate the skin to try to strip these lesions away, but this treatment is oftentimes disappointingly ineffective. Now, pityriasis alba is another finding common in kids prone to eczema. This is seen as light-colored, roundish areas on the cheeks, and if you feel the area, it often has a subtle, fine roughness or scale. It's more noticeable in the summer because the rest of the skin darkens a bit with the sun. Pityriasis alba usually responds to 1% hydrocortisone for about a week. We need to be careful to let parents know that the hydrocortisone will not immediately restore the pigment of the skin. It'll settle down the mild inflammation of the area that originally caused it to lose its pigment, and then allow for the area to heal with restoration of the pigment over time, usually weeks to months. Again, use the over-the-counter hydrocortisone for 5 to 7 days, and then continue to moisturize the area so it doesn't persist or recur. Now, pityriasis alba should not be confused with pityriasis rosea, that weird, scaly, Christmas tree pattern rash that we often see on the belly and backs of our patients, especially I think is in teenage girls, and it seems to happen a lot in the spring, right before their prom, when they've just bought a backless gown and they're very upset. And it takes 2 to 3 weeks or more to resolve, but there's nothing much to do about it. Do you see that a bit, Matt?
Yeah, for sure. My own little pityriasis rosea story is such that when I was a medical student, I suddenly had this rash. And being a good medical student, I went to the local medical student physician, who I later discerned was the person who couldn't get a job. And She told me I needed to be tested for any number of sundry and horrific diseases, including syphilis, which I guaranteed her was not a possibility. But
everyone with syphilis always says it's not a possibility.
I assured her in no uncertain terms that wasn't possible. But anyway, so instead I turned to a dermatologist, but did my research ahead of time and went to see a dermatologist over in Jersey. And he said, well, what do you think it is, young doctor? And I said, I think it's pityriasis rosea, although I'm sure I mispronounced it. And he said, excellent. Then you know there's nothing we can do for it, and this is your first, what is it when we used to give away our services? Professional courtesy.
Right.
Uh-huh.
And did you wear your backless gown?
Rob, we promised we wouldn't talk about that.
Okay, I'm sorry. All right. So then there's nummular eczema, which is a nearly perfect round area of eczema. And nummular is from the Latin nummulus, which means shaped like a coin, oval or circular. Now these spots can easily be confused with tinea or ringworm, and granuloma annulare, which is a funky, roundish, non-scaly phenomenon, although these other two conditions usually have raised areas on the outside of peripheral borders, whereas nummular eczema is uniformly scaly and flat. Often there are multiple lesions, whereas ringworm is mostly typically a single lesion. And just this week I had a mom come in, my child has ringworm all over it. I'm thinking, it's probably nummular eczema, and that's what it was.
Generally, the only ones with ringworm all over are those nasty wrestling kind of people.
Exactly.
So if a young child with eczema gets a severe flare-up with associated blisters, we need to consider the diagnosis of eczema herpeticum, which is caused by a cutaneous herpes viral infection occurring in children with atopic dermatitis. This condition is no surprise. Kids with eczema have reduced defenses against herpes and other topical type of viral invaders. Eczema herpeticum can be severe, and antiviral medications are often needed. Remember, any child with baseline eczema will, by definition, be at risk for more severe skin reactions from any conditions which can affect the skin, since their skin barrier is already compromised. Other conditions more prevalent in children with eczema include things like molluscum contagiosum, patago, and ringworm. Do you say patago or patago?
Impetigo.
I vary it. Chickenpox, of course, is even more torturous when a child has eczema, as you might imagine. And then there's psoriasis. We do see this condition in pediatrics, just not nearly as frequently as our colleagues in adult medicine do. The most common type of psoriasis is characterized by plaques, which are raised up on the skin like a sudden, well-defined, flat elevation. These lesions tend to have intense redness, a coarse and what's been referred to as a silvery scaling. I think it's more whitish, but kind of silvery, and very abrupt demarcations from the surrounding skin. And lastly, if a rash looks like eczema, but is insanely itchy, especially at night, and is not responding to treatment based on the presumption that it was eczema, we always need to consider the possibility of scabies.
Yeah.
And they used to say that scabies was a great imitator, Rob. Scabies and syphilis, right? Gosh, we're covering everything here today. We know that in younger kids and infants, scabies is less likely to affect the wrist like it often does in older kids. So that's not really a good tell for the babies. And also less likely to have the classic furrows that sometimes help us to identify it. If scabies is a consideration, it's simple to treat with an overnight slathering of some permethrin, also known as elamite, one of the great names for a drug, by the way. Eliminate mite, elamite. While definitely warning the child's parent that the child may actually get more itchy over the ensuing days because these little carcasses are left to deal with under the skin. These dead little critters are sitting under there, and your body has to break them down, and that can be kind of uncomfortable. And that's where sometimes you have to step in with some heavy-duty antihistamine.
Right. But I don't know about you, but a few times a year, Matt, I'll have someone who I'm really puzzled. It's really itchy. I'm not sure what's going on. Let's just elamite them overnight just to see if that helps. Right? Have you done that? I mean, and sometimes it seems to. So it really is no other test to do, and it's just a one treatment. So I think it can be worthwhile in these situations to try.
I'll tell you, the diciest part of diagnosing that, even though it can sometimes be a challenge to diagnose, is the word you use or the words you use when you're trying to break to a family if their child has scabies, right? Because it's more or less saying like, boy, your dad was a mass murderer, or there are horrible things going on in your child's skin. So I try to be very specifically vague when I say it looks like there may be a little mite thing going on here, and it is contagious, so we have to make sure we take care of the whole family. And once I've kind of made the introduction, eventually I roll around to using the word scabies, because that's the one that people are fearful of.
Right.
But it's important to understand that this is indeed contagious, and so generally when one person has it in the family, we've got to be very cognizant of the fact that either others have it or they are at great risk to have it.
Right. And also at the end of the explanation, you can also say, well, it could have been worse. You could have had lice. Because I think if anything strikes fear in our families, and especially the moms, it's lice. So like, okay, as long as it's not lice, we're okay.
But then that infers that it's lice. So when they come back in a week and they have lice, then now you've already said, this is a horrific, social dilemma for you, right?
Hopefully you're not missing lice as easy. So another biggie in differential diagnosis of eczema is irritant dermatitis, which is red and scaly, not as itchy, and can be caused by a common household chemical in soaps and even by deodorants. And a classic example of irritant dermatitis is the ring-like eczema rash on the buttocks, which some call toilet seat eczema. This is a localized reaction to cleansers such as Lysol and Clorox wipes used to clean toilet seats. It can also be seen with certain potty chairs due to chemicals in the plastic of these chairs. So when you see eczema only on the bottom, think irritant and try to remove the rash's source before jumping into a full-fledged eczema treatment. Again, in general, eczema usually does not like the buttocks. Irritant dermatitis can be treated with moisturizers and topical steroids, but the real key is getting rid of that chemical irritant. But this never happens in the Gotthold house because they don't clean their toilet seats. So they don't have any problem with toilet seat irritant rashes. Right, Matt?
Actually, Rob, our outhouse has a wooden seat.
Wow.
And I want to know how you know that deodorant can cause irritant dermatitis on the butt. Just to ask.
I read about it.
Yeah. All right. So before we wrap up our other things that look like classic atopic dermatitis like eczema, there's also seborrheic dermatitis, which we discussed in detail in our epic cradle cap episodes. Seborrheic dermatitis is very common. Sebderm, which is what those of us in the field call it sometimes, loves the eyebrows, the scalp, and the area behind the ears in infants. Rare causes of significant eczema, which can present as rashes in infants that's resistant to treatment, include immune deficiencies like Wiskott-Aldrich syndrome, which is always on the board, by the way.
It always is.
Always. Hyperimmunoglobulin E syndrome, rare lymphomas, and acrodermatitis enteropathica. So this one actually deserves a little bit of conversation, just because it's a super cool name, and it's a situation that involves a mineral. So acrodermatitis enteropathica is a recessively inherited partial defect in intestinal zinc absorption. Affected infants develop an angry red, vesiculobullous type of dermatitis, hair loss, diarrhea, ophthalmologic disorders, and even severe growth retardation. So when a rash that's perceived as being severe, unusual, or treatment resistant, it can be reasonable and helpful to sometimes do a bit of a workup, including a CBC with DIF and a zinc level. It can also be helpful to get an albumin level because sometimes protein deficiency can cause rashing. And lastly, immunoglobulin levels and immune titers to assess a child's immune function can also sometimes be helpful when you're trying to figure a rash out.
Right. So, okay, Maddie, you have a baby with some eczema. So what really is the big deal? You put some moisturizer on it, maybe you get some topical steroids. If it doesn't get better, it's kind of a nuisance, right? No big deal. Well, it is a big deal. Poorly controlled atopic dermatitis is a huge deal because of the atopic march. Now, do you like a good marching band, Maddie?
Well, only when I'm in the mood. I spent much of my time in high school on the bus going to marching band competitions with my baritone horn, so I'm kind of over that whole sentiment. It was really quite enough for me, although shout out the band geeks out there. Woohoo!
You were the real cool kid back in the South
always,
Jersey swamplands. Well, one of my holiday TV favorites coming up now is March of the Wooden Soldiers, the 1934 Babes in Toyland film, Laurel and Hardy. Did you ever see it?
No.
That's a no. Okay. And speaking of TV, Maddie, because I like to speak of TV. Did you know that It's the Great Pumpkin, the Charlie Brown Halloween TV special, was not shown on broadcast television this year because Apple TV now owns it and didn't show it? And that a Charlie Brown's Thanksgiving and a Charlie Brown's Christmas almost suffered the same fate. But a lot of people got upset, and Apple bowed to pressure and allowed it to air free on PBS, which I love both of those.
Wow. So as if Apple doesn't control enough things in the world, it's stockpiling our pop culture touchstones, right?
Exactly.
Oh, my gosh. All right. So patients with atopic dermatitis have much higher rates of allergic diseases than the general population. Up to 80% of children with atopic dermatitis will have asthma and or allergic rhinitis as they progress through childhood. This evolution from atopic dermatitis in infancy to allergic rhinitis and asthma in childhood and young adulthood is referred to as the atopic march or the allergic march. The main risk factors for atopic dermatitis that progress to the development of things like environmental allergies and asthma and food allergies are the early onset of eczema and the severity of the eczema. So only 8% of the general population has asthma, but 20 to 30% of the kids with mild atopic dermatitis will develop asthma. And 70% of the kids with severe atopic dermatitis will develop asthma. That's really astonishing.
And we
right?
see these kids all the time in our career.
We do. And for the parents that we actually kind of know well or feel like we can speak frankly to, we'll say, hey, it won't surprise me if down the road we're talking about your child's respiratory system as well, because oftentimes eczema portends that.
Yep.
So children with early eczema, the prevalence of IgE-mediated food allergy with a possibility of severe reactions to food is 35%. Yep, you heard it here, 35%. This disturbing fact was noted in a study from Allergy, Asthma, and Immunology in 2017. Atopic dermatitis is considered the major risk factor for the development of food allergies in a child. The current hypothesis is that sensitization, which occurs cutaneously through compromised skin barriers, lead to food sensitization and food allergies. Specifically, defects in serine peptidase inhibitor, Kazol type 5, Spinks 5, there we go, Spinks brothers again, are associated with food allergy that can be food challenge proven. Well, we already discussed the genetics, but there are also epigenetic factors which affect the course of atopic dermatitis, which include behavior, diet, the expression of genes over generations, and innate Th2 immunity. There are also factors related to environmental stressors, like cold weather and seasonal changes, and yes, even the all-inclusive, ever-elusive microbiome. As we mentioned, early and aggressive treatment of atopic dermatitis can help to alter or stop this allergic march.
And eczema has huge negative health effects beyond the allergic march, often related to that god-awful chronic itch. In a study in Journal of Dermatology in 2016, 86% of kids with moderate to severe eczema recorded itching daily with pain, and 61% reported severe, unbearable itching. Over half of these children suffered from sleep disturbances more than 5 nights per week, and 42% reported the itching lasting longer than 18 hours a day, which is, oh my God, so much. And it's no wonder that kids with moderate to severe eczema have over a 40% prevalence of anxiety and significantly more depression. Kids with atopic dermatitis also have an increased rate of attention deficit hyperactivity disorder when compared to their peers, and an increased risk of suicide. No one really knows why the ADHD incidence is elevated in kids with eczema. Some think it's from chronic sleep deprivation. Others speculate it's due to increased inflammatory chemicals present in the body, often from infancy, that affects the brain development of the child as it grows up, and that's pretty scary stuff.
So, ladies and gentlemen, and Rob, now we are going to do a shallow dive into the connection of eczema and food allergies. Our next episode will be on food allergies, but it's hard not to relate the two topics briefly as we talk about atopic dermatitis. We know that in sensitized patients, food allergens can induce hives, itching, and eczema flares. There have been different recommendations, and we've covered them in podcasts over the years, concerning screening for sensitization to egg early on in kids with eczema introducing peanut products by 6 months of age in infants with eczema, and even sending infants with bad eczema to an allergist before introducing allergenic foods. But now, more and more evidence support us being even more aggressive with the early introduction of high allergenic foods like milk, eggs, peanuts, tree nuts, fish, shellfish, soy, and the newest, fastest growing allergen, sesame.
Sesame.
To young infants, sesame, open sesame, especially if they have eczema. So these things should be introduced earlier if a child has eczema. Many bigwigs in pediatric allergy, including Dr. Spergel, now preach starting feeding infants at 4 to 6 months of age and giving them all of these foods, one at a time, of course. There are commercial products out there that are marketed for just this concept, introducing a variety of potentially allergenic food to a baby in a calculated, protocol-driven way. One of them is Ready, Set, Food, a program that peanut products and eggs and milk together come in a kit, and they tell you exactly how to do it. Another product, Spoonful One, the pediatricians have directly advertised to us, has 16 different food proteins included in its plan. What do you think of these, Roberto?
You know, I had not really considered it as much before, but I'm getting more and more open to some of these products. I'm a little bit more hesitant about the one with 16 different food allergens together that you give at once, which also includes shellfish like shrimp, and you cannot use that if the child is halal or kosher. And we're going to touch base on all of that in the next episode. One may ask, why does eczema lead to an increase in food allergies? Well, a fascinating hypothesis is that it all goes back to that itch and scratch cycle we talked about. Babies tend to be messy eaters and touch everything. And the hypothesis is that when babies and young children touch and scratch their skin when they have eczema, food proteins in their hands and nails get introduced into the body through the skin, not by eating. And the theory is that these food proteins in the skin rev up mast cells in the skin and lead to a robust IgE response. Remember, these kids, in addition to having physically compromised barriers, also have altered immune dysregulation. So again, controlling the itch, and the scratch especially, could be a way to reduce later food allergies. And also makes you think that, yes, make sure they cut those fingernails. Dr. Spergel also made a point never to get a blood IgE food panel for kids with eczema. I don't know about you, but I stopped doing that. How about you? The food panels.
Oh,
yep. You should
Mm-hmm.
only test for foods that are actually being eaten. For me, I mostly leave it to the allergists to do testing, and I pretty much have stopped doing any IgE food tests. There are lots of children out there with severe eczema who have been put on severely limited diets based on fears of food allergy fueled by these blood tests. Many of these diet restrictions are not warranted, and these kids need to get skin tested and then food challenges to prevent malnutrition from unnecessarily severely restricted diets. Okay, we've talked a lot about eczema, but some of the most exciting parts is the new treatments, including the proactive therapy. And that's going to be for the next episode, which will come back before Christmas. And we'll also include more on food allergies. So, Maddie, anything else you want to say?
Just happy Hanukkah ahead of time, because I never know the dates on that thing.
December 10th. December 10th.
There you go.
Thank you very
Okay,
much.
my friend.
I look forward
My
to 8
pleasure.
presents from you, Matt.
I'll see what I can do.
Okay, all right. So be safe. Say goodnight, Matt.
All right. Good night, Rob.
Good night,
Take care.
Moon.
Bye-bye. All those things.
This here's the story of Cassius Clay, who changed his name to Muhammad Ali. He knows how to talk and he knows how to fight, and all the contenders were beat out of sight. Sing Muhammad, Muhammad Ali. He floats like a butterfly, stings like a bee. Muhammad, the black Superman, who
Podcast Pediatricians Productions. All rights reserved.